Good evening all to the 133rd session of the weekly huddle. I'm your host Anoop Agrawal, and joining me today is my friend and co-host Pratik. We both are cardiologists at KIMS Hospital. Topic that we have chosen today is something that I can say this with certainty that pretty much every single doctor encounters in his or her clinical practice. These are certain aspects of clinical medicine that you cannot just stay away from. And be it urine culture, be it blood culture, be it body fluid cultures, but somewhere microbiology is a very inherent aspect of we as a physician. And while we may not have the requisite expertise to practice as an infectious disease specialist, we are expected to at least know the very basics of how infectious disease work, particularly the tests that we are ordering. And culture sensitivity to a certain degree, it just looks like magic. You give a sample, and after a couple of days, the microbiology lab, it tells you which organism it is, and it also tells you which antibiotic to choose. While it sounds quite simple and quite straightforward, I'm pretty sure there is a lot more science into it. And I'm sure at least a few of us have at times stumbled upon the kind of culture sensitivity reports we get. Also, whenever I hear of a culture and sensitivity, I'm also reminded of the lab experiments that we used to do during our MBBS days, where you would have an agar plate and you would impregnate it with the culture colonies, and you would see that which of those colonies would grow or not grow, aka inhibit with the antibiotics. So now we have got these culture reports where literally the report tells you about 20, 25 antibiotics, and it tells you whether the organism is sensitive or not. It gives you some MIC value. Many of them are intermediate, many of them are resistant, and the MIC values are itself all over the place. So at times, I think we as a physician, we simply just look at the right side of the report and just look at all those which are sensitive market and choose one antibiotic out of it. So while the culture and sensitivity was, I believe, was to make our life easy, to a certain degree, it does make it complex, because now we have to understand the various intricacies of how these culture sensitivity reports are generated. Are they done through a usual agar plate method where you actually know that these drugs are inhibiting the colonies, or they are done through some genetic analysis, or they are done through some other analysis where literally within a matter of hours, you get to know that which organism is sensitive or resistant to which. And then some of the reports also talks about antibiotic synergism, where it also talks about how the two antibiotics might work better for this bacteria rather than one. So I believe the field has certainly become far more sophisticated, and I do not think at this point of time it will be fair for us not to know about the very basics of this. And to help us understand the nitty-gritties of this topic, I'm joined with Dr. Pratik Patil. He is an infectious disease specialist at KIMS Hospital. As a courtesy, I always start the discussion asking a clinical question to my colleague Praneeth. But in this particular case, while I do have an example or a demo case that I can start the discussion, but I guess a lot of discussion today is going to be increasing our understanding of how this culture sensitivity is actually carried away. So I'll directly reach out to Dr. Pratik for his inputs and maybe give us a little bit of idea about how these things are carried. And while I keep mentioning that Huddle is not a speaker and audience model, this discussion may actually be a dialogue between me and Dr. Pratik, unless my audience, they give their inputs or they have any questions that they ask, because then I will be able to open the discussion with more questions and more thoughts. So for the next about 40 minutes or so, I will continue my discussion with Dr. Pratik. I will ask his insights about what these culture and sensitivity, what magic happens in the background. But to not make it monotonous, I would request my attendees to either submit your questions or participate in the discussion to the best that you can. So the case that I put up is a very generic case. It's a 58-year-old female. She has diabetes, hypertension, a mild coronary artery disease for which she's on conservative management, otherwise fine, comes for a routine checkup, complaints of frequency and dysuria. Urine analysis shows that it is loaded with pus cells, and a urine culture is done, which suggests that the organism grown is E. coli. And amongst the various patterns, it does mention that it is resistant to some and sensitivity to some. Now, which of the drug this particular bacteria is sensitive or resistant to, that is not the point of discussion today. But the idea here is how the microbiology lab would have reached that conclusion. Is it different for urine? Is it different for blood? Is it different for other body fluids? And as a physician, how we should interpret it. So Pratik sir, my question to you is, and this may be a good starting point, that please walk us through what happens when this urine sample reaches the lab for culture sensitivity, because my guess would be that the sample is put in a broth, and then the broth kind of, it is put in through a culture medium where it grows over time, and then you would take those colonies, put it in a agar medium, and try and see which of the antibiotics it is sensitive to, which of those it is resistant to. Please walk us through how these things actually happen and how we should be interpreting these reports. Pratik sir.
Hello. Hi, sir. Good evening, all. Am I audible?
Yes, you are, sir. Please go ahead.
Okay, fine. So yes, you are partly right. Partly there are few updates which have come from the many years now. So let's say when the urine sample is taken, as the case which is being discussed, the urine sample, when it reaches the lab, they take the urine and they inoculate into the agars, which is basically a McConkey agar, chocolate agar, and blood agar. So they put it on that and they inoculate it or incubate it. Okay, so once that is going for incubation, and then they check the plates after a few hours or every day at certain points to see if there is any growth of bacteria. So that is about let's talk about the body fluids and the blood culture. And in the body fluids, roughly we will say the sterile body fluids and non-sterile body fluids. In this, the sterile body fluids, I mean pleural fluid, it can be pericardial fluid, CSF, ascitic fluid. These are the sterile body fluids which can be inoculated into the liquid broth media, which can be, let us say, blood culture bottle. But the non-sterile body fluids like sputum or ET secretions or urinary sample, they do not get inoculated into the liquid media. They are inoculated into the solid culture plates, which are agars basically. So once these non-sterile fluids are inoculated, they grow after a time, and then the microbiologists read the plate after some time, and then they can see the type of colony morphology on the different agars. So, and then once the growth is there, depending on the colony morphology, and again, from the colonies that they find, they make the stains out of it. And then they identify whether it's a gram negative, gram positive, and all those things. So that is first part. Second thing is, once there is a standard inoculum in each colony, they take it and then they put it for the sensitivity. Now, when it comes to the sensitivity, there are two methods. There is something called disk diffusion method or K-Beer method, which was old method, which is still being practiced even in bigger setups for certain indications. And nowadays, most of the hospitals have automated sensitivity tests like Vitek machine. So just for this, can I share some slides here? Can you enable the slide sharing?
I think I will be able to. Let me see. Okay. Sir, see if you are able to share the slides now.
Share or screen sharing?
Yeah, share it, and then you should be able to.
Yeah. Yes. Can you share? Can you see my screen now?
I am not able to see it yet, sir. No. Pranit, are you able to see Dr. Pratik's slides?
No.
Okay. Pratik, sir, you are getting the share screen option though, right?
Yes, I did that. I was able to
Okay.
see that option.
All right.
One moment.
Let me
Or
see if I can changes. Okay, it says who can share all participants. I think the option is open. Sir, if not, just send me just WhatsApp me the slides.
I
will
have WhatsApp you slides already. You have my slides already, which I have shared with you.
Just 1 second. You tell me which of those slides I will share
See,
you
the
the
first
slide.
slide itself. Let's say the first
Okay.
slide itself.
All right, let me do that. 1 second. Okay. I will do that, sir. In just 1 second, I will be able to. Okay. Are you able to see now? Pranit, are you
Yes,
able
Anoop.
to see?
Yes, Anoop. Yes, Anoop.
Yeah. Okay, sir, please go ahead.
Yeah. So this is what I was talking about. So this is the disk, which is basically a disk diffusion method where this is a agar plate, and in that there are two antibiotic discs, and you can see the zone around it, which is the zone of inhibition. And based on the diameter, the microbiologists decide whether it is a sensitive or resistant. That is the one older type of how to identify whether it's some antibiotic sensitive or resistant. Now the second one, the picture I'm showing is called E-strip. Basically, there is a gradient of antibiotic on the strip. If you can see carefully, there are numbers written on that strip. Okay, and the number where the zone of inhibition starts, let's say in this picture, it is around 0.75. So that's what is the MIC, let us say. So MIC description is what I'll come to that later. What is MIC meaning? So that's how they decide whether it is sensitive or not. So these are the methods how they identify. Now, another method which I mentioned is YTEC. So if you can take any other slide afterward, any later slide. If you can, yeah. So let's say this is the first one, minimum MIC, which I was referring to. It's the minimum inhibitory concentration of an antibiotic that is required to inhibit the visible growth of bacteria on agar or in the broth. So this is basically needed to see whether it is effective at what concentration. Can we move to the next slide? Breakpoint. So this is a highest possible plasma concentration that will be required to inhibit the concentration. And this is important to know the breakpoint because you cannot give the antibiotic at any dose. There is a safe dose or the maximum safety limit beyond which we cannot give. So if you give highest any concentration of the possible that given drug in the lab, you will achieve the inhibition at some point. However, we may not be able to give that same achieve that same concentration in the human body in vivo. So that's why what is the safety limit of an antibiotic, which at which it will be able to inhibit the growth in the body. So that's why breakpoint is important. So unless your breakpoint is within the that desired MIC, it will not be useful to use that given antibiotic. So can you move to the next slide, please, again? Yeah, PKPD, I'll come that a little late probably. Yeah, so this is what we categorize based on the observed MICs or the size of the zone or the dimensions of the zone. A particular antibiotic for that given bacteria in that given sample and in given that in the let's say if it's urine or blood or it's a CSF, it can be sensitive, intermediate, and resistant. So why I'm saying all this given sample or given site because sometimes the sensitivities can be different in different sites, or the breakpoints can be different because of the tissue concentration of that given antibiotic. Let's say the Streptococcus pneumoniae that we commonly see, let's say, if it is in the brain, the ceftriaxone may not be able to achieve the same concentration in the brain as in the blood. So the MIC breakpoints are different, though it is the same bacteria. So that's how the interpretation changes. So that's why it is important to know which is the sample and which is the bacteria and which is the antibiotic. So that is basically the PK/PD. So PK is basically pharmacokinetics. When you give a particular dosage of drug, what is the concentration it's achieving in a body, in the body. And PD is the pharmacodynamics. So when the drug is reaching a particular concentration, what are the pharmacologic effects it achieves in the body? So that is pharmacodynamics. So the efficacy of a drug for particular infection depends on the PK/PD principles. So unless your drug achieves the good concentration in the tissue where you have an infection, you will not see the improvement. Let's say, just for example, since we are talking about urinary infection, the tigecycline is a drug which does not get secreted in the urine. So even if you have a E. coli which is sensitive in the urine, and if you give tigecycline, it will not work. Same way, linezolid. So that is why it is important to know the mechanism of action of drug and the PK/PD principles of the drug. What is the route of excretion or metabolism for particular drug? So can we move to the next slide? Where we have mentioned the sensitivity reports, just for one moment. Next, please. Yeah, like here we can see there is a bacteria which has been identified as methicillin sensitive Staph aureus, and you can see the expected values being sensitive, intermediate, and resistant. Sensitive means it has the breakpoint. It is the breakpoint. Anything less than that is sensitive. Intermediate is in situations where you can probably try using high dosages, infusions, and then you can overcome that resistant. And resistant is very high values of MIC, where physiologically it is not possible to overcome that resistance in the standard dosages. So that is what the clinical takeaway from these slides. And then that's interpretation with observed MIC. So you need to see what is.
Sorry, go ahead. Go ahead. First, you finish.
Hello. Sorry, sir. I missed you. I got a call. So
yeah, no, you please finish what you are saying. Then I will ask my question. You please finish.
Yeah. So this is what we need to see in the any culture report, be it whatever the organism or whatever is this site. So we can see there are two important columns that we need to focus. What is the observed MIC and what is the sensitive? See, what happens many of the times is just observed MIC is what is looked at. So let's say here in this report, if you can see, the benzyl penicillin has 0.5 MIC, and let's say levofloxacin has 0.12 as the MIC. And let's say the tigecycline. So that also has a 0.12 MIC. So does that mean the efficacy of levofloxacin and tigecycline is same for that given bacteria, because their observed MIC is same? But it's not the same. So since how to identify that? There is some there is a concept called efficacy ratio, which is basically the ratio of the MIC breakpoint divided by the observed MIC. So basically, let's say in this case, the MIC breakpoint for levofloxacin is 1, and observed MIC is 0.12. And same for tigecycline, let's say is 0.5, and the tigecycline is 0.12. So you can see that the ratio, efficacy ratio for levofloxacin is 8, and that is nearly 4 for the tigecycline. So if you give a standard dose of levofloxacin and tigecycline, in this case, it means the levofloxacin, since it has a higher efficacy ratio, it will be a better drug. However,
Pratik sir, yeah, please,
it
please
changes
continue.
slightly. It changes slightly if even if it was otherwise. Let's say if there was a situation where the tigecycline has a better efficacy ratio and levofloxacin has lesser. But if it is a urine isolate, then it doesn't apply because tigecycline cannot get secreted in the urine. So always whenever we are comparing the different drugs, we need to look at all these values. Same time, we need to know where is the infection and then whether the antibiotic which we are considering is able to achieve the concentration or whether it reaches that site of infection. That is more important. Yeah, can we have the question from your end now?
Pratik sir, first question. I'm just looking at this report, and I would again suggest to my attendees that if you do have any questions, you put it in the chat box or you raise your hand. I'll give you a chance to speak. So, Pratik sir, I'm just looking at the very top. It says investigation blood culture, and then it says method BACT alert, or I'm guessing that's BACTAC alert. What is that BACT? If you could walk us through.
Okay. So Bacter alert is basically it's the liquid culture media. Okay. So
Okay.
Bacter alert bottles. If you see the when we order the blood culture now, there are bottles which are sent to us, and then the culture when we draw the blood culture and it is put in those bottles which have the liquid culture media, which is an enrichment broth, which facilitates the growth of the bacteria compared to the direct media, direct agar plates. So what happens is the blood cultures which are taken, so they are collected in these bottles and they are incubated in the automated incubators. And as the bacterial growth happens, the bacteria use the media, they produce the carbon dioxide through the metabolism. And once the carbon dioxide reaches a threshold in that bottle, the machine is able to identify that as a signal, and it shows a we say it's flagging. It gives a signal or there is a light that blinks. So the lab technician or the microbiologist is able to know that there is something positive or there is a threshold level of bacteria that is growing, and then they take out the tube. So that is the difference between the cultures and the other lab tests. So other lab tests, you send it, there is a certain time, and then it comes back as positive, negative, or whatever the value it is. But the cultures are different. The cultures are like a real time. It's like ongoing. So it can come any moment. So first of all, for clinicians, it is important to know that you should keep tracking the cultures, especially in sicker patients. So we need to keep talking to the lab, to the microbiologist to know what is happening. It's not that you send a culture and only at 48 hours you talk to the microbiologist. It's not. You need to, because if you have a really sick patient, within few hours, like 5 to 6 hours also, your blood culture can flag positive. So that's what I mean by flag positive, that culture has adequate bacteria and the machine can detect it and it gives an indicator or flag positivity. And you can take so once there is some indication like this, you can take a small broth from the bottle. The microbiologists make the gram stains and then they can see the bacteria in that. Based on this, they can tell you what type of bacteria it is, whether it's a gram positive, gram negative, sometimes yeast. This is the preliminary information you can get if the blood culture is flag positive. And then once this is positive, or once the bottle gives, these are called liquid indicator tubes. So once the indicator is there is an indication. From this broth, they take a standard inoculum and then they plate it on the culture media, which is the blood agar, chocolate agar, McConkey agar. So based on type of bacteria, let's say if it's a gram negative, they put it on McConkey and blood. If it's gram positive, they put it on the blood and chocolate agar. And then when the colonies grow on that, from there again a standard inoculum of a colony is taken and that goes into the sensitivity card. So like we were discussing the Kirby Beer method or disk diffusion method, and the e-strip method. But nowadays, what is used is the automated sensitivity tests, which is basically there are different types of cards available, which have the given sensitivities of the different drugs according to the bacteria, and it is automated. Basically, the machine calculates what is the sensitivity, what is the resistance, and likewise, there are different types of cards for the gram-negative organisms, gram-positive organisms, fungal infections like Candida. So this is chosen, which one to use is decided by the microbiologist based on the phenotypic morphology of the colonies and the gram stain. So that is how. So the report, what we just discussing now, the values and the different antibiotics and the different values of MIC, this is calculated and analyzed by the machine. That is what we say the Vitek machine. These are different type of automated sensitivity tests like Vitek, or you have a different Bitman Coulter, or there are different other types of companies which come up with the different automated drug sensitivity tests. So this is a type of automated sensitivity test. Bactalert is a type of bottle, and then there are different types of sensitivity cards that they do it with the machine.
Thank you, sir. I'll just move on with the same question. So Bacti alert, you explained very well. Based upon what you have told us so far, what I'm assuming is for urine culture, there won't be a Bacti alert, right? Because we will not put it in that bottle. Is that correct?
Correct. That's right.
Okay. So urine will go into a direct solid growth medium like an agar.
Correct. See, and
So
again, see, most of the labs, most of the standard labs or good labs, at the end, they will write it. What is the method of doing the sensitivity tests? Let's say there will be a footnote somewhere. The sensitivity is done using the Vitek machine, or there may be sometimes there is a version, what version of Vitek has been used to identify the sensitivity. So most of them, then sometimes when you just see the sensitive resistant, then we know that it's by, or sometimes they write the zones. So what is the observed zone? 21 millimeters, 25 millimeters, 4 millimeters. That is the disk diffusion. So that is a disk. They should write that the sensitivity is analyzed using the disk diffusion method. So that methodology they have to mention. Any good lab will mention the methodology by which they have done the sensitivity tests.
So, sir, when you mentioned about this back-tag or back-tea where the bottles are put in an incubator,
Yes.
what happens to the solid growth media? Are they also put in the same incubator with the same signal that comes in, or there is a different way of
there is a
processing that?
different incubator, and then they just check the test, the culture media every standard intervals. Let's say they have timings for that, so they keep checking the plates whether there is a growth of colonies. They streak it in a standard manner, and then when the every few hours they check, and if there is a colony growth, then they process it for further. So there is an incubator, but there is no automated alert that it will come. So that is a manual way to keep seeing the plates.
And the next question is, it's on the report, it says organism isolated methicillin sensitive Staph aureus. Now,
yes,
what you told us that the microbiologist, it takes a particular inoculum, whether it could be from the bottle or from the agar plate, and then he or she defines whether this is gram positive or gram negative and whatnot. But
yes.
Is it a manual intervention to define whether it is Staph aureus, or is there a machine which just looks at these colonies and does some magic analysis and tells that it is Staph aureus? How do they reach to this conclusion?
See, it's both actually. Because let's say on the first, like I told you, let's talk about, let's say, the blood culture. Once they see the positivity on the automated machine, they take a gram stain. So gram stain, it's easy. In 20-30 minutes, you can see whether it's a gram positive, gram negative. So, and then once it's done, then it goes to the agar plates, and then you plate it on different media like we discussed. So on that plates also, you can see the different morphology. So let's say the E. coli appears in a different way. The Klebsiella has a different morphology. The Pseudomonas, the Acinetobacter, each bacteria has a different morphology. Let's say the next step, once as a clinician, what I do every day is, let's say when somebody is growing a gram negative, next question for me is whether it's a lactose fermenter or non-lactose fermenter. That you can easily see on a McConkey media, because anything that lactose fermenter, you can see there is a zone of clearing. So then most of the Enterobacteriaceae are lactose fermenters. However, the Pseudomonas, the Acinetobacter, they are not lactose fermenters. They are there are some other type of bacteria which are non-lactose fermenters. So this gives you another lead. What is the possible organism that you are looking at? Among the non-lactose fermenters, there are some biochemical tests like oxidase. So Pseudomonas is oxidase positive, Acinetobacter is negative. So these are all tests that are actually done, which we read it in microbiology, but this is still being practiced, and still it gives you the lead to treat these infections appropriately even before final culture is ready. Because from the time you send the blood culture, let's say I'm talking about blood culture first, until you get the final sensitivity, still there is at least 36 hours time gap. And if you're not on your right therapy, you can still lose the patient, or your outcomes are not as good. So there is a live, it's real time checking, like I said. And each of these steps is important for me to decide whether I need to change my antibiotic, whether my antibiotic is correct. Do I need to modify my antibiotic based on the available information till that point, till I get the final sensitivity? So all these things are done. And then once the colony is grown, then it goes into the Vitek machine for the automated sensitivity. And then Vitek also identifies that bacteria. Let's say we thought, let's say gram negative. So Vitek will identify what it is. But a microbiologist is able to tell you what is the likely bacteria even before you go to the Vitek report. So they can tell you the identification of the organism on most of the occasions. Sometimes there are similar looking bacteria, so they may go wrong, but many times you can identify at least the bacteria based on the colony morphology on the agar plates. So that's about the ID. Sensitivity, they can't, obviously they cannot predict just looking at the plates. Similarly, this is about the gram negatives. Similarly, gram positives, there is something called hemolysis. So alpha hemolytic, beta hemolytic, there is a tinge, let's say the greenish tinge due to the hemolysis or zone of clearing. There are other like gram negatives, there is a swarming that is characteristic of a Proteus. There are some bacteria which have a typical smell. So all these tests or the features of different bacteria can give you the at least early identification.
Sir, I'm amazed with your answer that even nowadays, all that very basic that we learned in microbiology, which is lactose fermenting or oxidase and whatnot, all of them, they have real life practical applications. That is what you are saying, that these things are happening every day in a microbiology lab. Is that correct?
Absolutely, absolutely, yes.
Okay. And then, sir, last question again in this report only. So now I have got all these antibiotics and I have got all these MICs which are listed here. So my guess is this report is generated from probably a Vitek or a Vitek kind of machine. That is my guess, because I don't think, or please correct me if I'm wrong, that these reports, they are not coming from disk diffusion, or they are not coming from your easy strip, right? Is that the correct information?
Correct. This is by the Vitek. Yeah. Can you scroll down some more slides? I can show you which is the disk diffusion. You can see the report. Yeah. So this one, you can see this report here. Here, the report is only the sensitive or resistant, right? So in this, you can see that the antibiotic susceptibility in the footnotes, you can see the second line, antibiotic susceptibility testing done by disk diffusion. And the last footnote is its MIC has been interpreted and reported as per CLSR or UCAST. These are basically the CLSR is American and UCAST is a European microbiological society, which defines the criteria when you call sensitive and resistant based on the different methodologies that are being used. So this is what is an example of a disk diffusion sensitivity testing.
So in this particular report, we can't look at the efficacy ratio like you were looking at the previous one,
yes.
correct?
So in this, we can't use that. Can you slide some more? I think there is another report I have. Yeah, go ahead. Not the previous slide. Keep. This is another disk diffusion. I'll tell you something later if you have the time. Keep going, please. Yeah, keep moving, please. These are all similar reports. Keep going. Yeah. Yeah. Can you stop here? Yeah, this is another urine culture where you can see there is a disk diffusion is the probable test of the way they have tested, and here again it's just mentioning sensitivity and moderate and resistant. Yeah, so that's it. Anything else you have to ask, Dr. Anoop?
So I'll again go back to this question, the very first report that we were talking about. So in this report, there is a panel of antibiotics, right? And this is most likely an automated machine like a Vitek or something. So my questions are, who chooses this panel of antibiotic? Is it the card which has got a fixed set of antibiotics which are there?
Yes. So the card is chosen by the microbiologist, and each card has a set of bacteria based on the morphology of the bacteria. Let's say, like I told you, gram-negative first. So if you have a gram-negative gram-negative bacteria, which is a lactose fermenting, then they will choose a type of card which has set of antibiotics which is supposed to be reported for that bacteria. Okay. So this is not determined by the microbiologist. They can choose a panel, but in that panel, what are the drugs to be tested? This is prefixed or pre-decided. There are different panels even in gram-negative. Let's say the NLF or non-lactose fermenter. There is a set of bacteria antibiotics which I want to choose. That will be automated. I mean, that will be fixed and that will be reported. Let's say gram-positive. In this case, they must have used a gram-positive card, and that's why you are seeing a set of antibiotics here. Okay, so let's say when we dissect further into this report, let's say they have used in this clindamycin, linezolid, daptomycin, teicoplanin, vancomycin. These are the drugs which are only seen in the gram-positive bacteria reports. If you are seeing these drugs even mentioned in the report with identification as a gram-negative organism, any gram-negative, then that lab is not good. So any good lab should not report, even mention that this antibiotics in their report. Even if they say, okay, these antibiotics are there and they're resistant, it's not the way they should report any of these things. So these antibiotics should be mentioned only if you are talking about a gram-positive bacteria. So this is how it is. Let's say the benzyl penicillin, oxa, gentamicin, and ciprofloxacin. These are all decided because it is a gram-positive organism, and these are the antibiotics which have a gram-positive cover. Okay. Now again, in this, if you can see, carbapenems are not mentioned. It happens many a times that we are giving some BLBLIs like ceftriaxone, sulbactam, or meropenem. But your report says, okay, it's a Staph aureus, MSSA. So, but it is not mentioned in that report. So, will it work? Will it not work? If you call to the microbiologist, it says, okay, it is MSSA. This is not being given in the report because they are not supposed to report that as per the guidelines, which are decided by the CLSI. And though all these drugs, what we mentioned, the third generation cephalosporins or carbapenems, they have activity against MSSA, but they are not good drugs. And you better use a drug which is gram-positive specific. So that's why they are not being used in these. So you can see in this, the third generation cephalosporins are not mentioned. You have penicillins, you have these drugs which we mentioned, which have only gram-positive cover. You have tetracyclines and cotrimoxazole, which are good drugs for the gram-positive and not so good drugs for the gram-negatives.
Okay, sir. So the question, another question. This is the last question for this report. When you say disk diffusion, we understand how it works. There is a growth. You put an antibiotic onto it, and with that antibiotic, it inhibits growth. You see a area of inhibition, and that way you know that whether this bacteria is sensitive or resistant. Same thing is with your easy strip. It makes sense. This is intuitive to us. I understand that all these Vitek methods, they are automated, but do you know, or if you could give us a little bit of idea of how the machine concludes what is the observed MIC? Do they do a mini disk diffusion inside, or how is the machine actually coming to this conclusion?
Yes. So see, when you do a automated machine, so basically they inoculate, they use a standard inoculum of the culture media, the bacterial colony, and the card that they use, it has a fixed concentration of a particular drug. Okay. So instead of doing it manually, it is doing on its own. So it is the same principle. Like in discs, every disc, it has a certain concentration of a drug, and you are using a standard inoculum of a bacteria on that plate. So it is the same thing which you are doing. You are using a standard inoculum of the bacteria, and the plate, the panel which you are choosing, the gram positive or gram negative panel, or this thing, that also has a fixed set of concentration of a drug, and then it does the test on its own. So it interprets on its own. So it's just the principle remains the same, just method of analysis is different.
Sir, the second report that now I am referring to, this is your disk diffusion method. This is not using a card, which means in this particular analysis, the microbiologist has decided to use these or antibiotics which are sitting there. Is that a correct interpretation?
That's right. So that is the another thing which I have chosen why this report is mentioned here. See, if you see this, one moment. Yes. So why I had included this report in my discussion is you can see the amikacin being highlighted here last. It's underlined here. See, amikacin is a drug which has a pure gram-negative cover. It does not cover Staph aureus or any gram-positive, and it is wrongly mentioned in this report that it is sensitive. So you should not go by the report and use amikacin for such patients. So that is why the automated methods are better, because it avoids such errors.
So this is a human error you are saying?
Yes, it is the error from the microbiologist.
This is an error from the microbiologist. Okay, correct. So when a microbiologist is using a disk diffusion, then microbiologist has an option of choosing which antibiotics to choose, right, for the resistance pattern?
Yes.
Which means as a clinician, I can ask the microbiologist, even after I get a report, that, hey, can you use the same bacteria and test it on an antibiotic which I'm using right now?
Yes. So that is what I also do sometimes. See,
okay.
If I want, I want to choose, I want to know the sensitivity of one particular antibiotic, then I will request them. But again, it has to be done immediately, because after a certain time, they usually discard the specimen. So if you want a particular antibiotic, you have to request them to see by the disk diffusion, because it is not included in the panel. Let's say doxycycline. If I want to use, let's say for some gram negative and all, it is not included in many of the panels. So I have to request them specifically. Let's say fosfomycin. If you can switch to the next some slides, I can elaborate on that sometimes. Can you move forward? Next slide, please. Again, more. Next slide. Yeah, I think. Can you go back previous? Yes, here. If you see here in the second half of the picture, you can see the fosfomycin. They have mentioned the sizes here: 23 millimeters, and then ceftazidime avibactam 22 millimeters. Can you see that here?
Yes,
they have mentioned. So this is on the special request, or as a usual when there are certain antibiotics which are resistant. Let's say they do it commonly for the carbapenem resistant organisms. So fosfomycin is not part of the routine panel that comes, that gram negative this thing card. So that's why they do this second level of antibiotics as an add-on test. So fosfomycin is done here as a disk diffusion method. Ceftazidime avibactam is not included in this card. That's why they have done it separately as a disk diffusion. So, and there is a, see, and again, you can see there is a colistin or polymyxin mentioned here. And here the colistin and polymyxin MIC is done with the use of E-strip. E-strips, so the way to obtain the MIC is either you use an automated machine or you use the E-strips. E-strips can give you the exact MIC. Disk diffusion cannot give you the MICs. It can give you the zone of inhibition or diameter of the inhibition.
Sir, in the same report, I read synergism of ceftazidime, avibactam, and aztreonam observed with capitals kindly correlate
Correct.
clinically.
Yes.
Can you guide us through what this line means?
Yes. Can you move to the next slide, please? I think. Yes. So this is what. Yeah. No. I think that's previous. Yes. This is fine. See, in this, the second picture, I'll show you the first thing. Second picture, what if you see, there are two discs two discs you can see. On one disc, there is written 80, that is aztreonam disc, and there is another disc where there is a CZA, that is basically a ceftazidime and avibactam. And if you see around them, there is a very small zone around them. There is not much zone of inhibition around that, but there is a synergism present there. Okay, so between them there is no growth at all. So that's when you call individually the drug is resistant because there is not much zone, but though they are far away, the area between them is clear. There is no bacterial growth. That's when you call it a synergism present. That's one way to test it. If you come to the first picture where there is a E strip you can see, and there is a aztreonam disc. That E strip is for the ceftazidime avibactam, and there is a aztreonam disc next to that at certain fixed distance, and there is a then you can analyze it. So basically you can see there is a aztreonam very small zone on the away from the E strip. You see the outer side, there is a very small zone. However, if you see, yes, on this side, there is no growth at all. The zone of inhibition is extending till to E strip here. There is nothing in between. So this is a synergism positive between the two. Aztreonam individually is resistant. And if you carefully see the zone of inhibition for the E strip, it is somewhere near 0.75 or 0.1. Here, on the other side of the E strip. Can you see this? Yes, that's where the zone of inhibition starts. That's how you read the MIC for that given antibiotic for that given bacteria. So here it's 0.1 or so, sorry, 1. So it is within the sensitivity limit. So in this, I would report, or how I would read this report is, ceftazidime avibactam as an individual is sensitive, aztreonam individual drug is resistant, and there is a synergy of ceftazidime avibactam and aztreonam. So that's how the report would be.
Sir, this adds more question in my mind. So now let us take either this example or this example. Now you have got two antibiotic discs on the same disc that they're studying. What you have explained is understandable. My question is, how did microbiologists choose these two antibiotics only? Why not choose aztreonam plus clindamycin? Let's take for example. Why Zavicefta and aztreonam? How did they come to the conclusion?
No, see, this is the reason. See, basically, the intention of using two drugs is we want to know the molecule which is aztreonam avibactam. Okay, so whether usage of aztreonam avibactam is likely to work for this given gram negative or not. When you see in the ceftazidime avibactam, it is a gram negative which has a cover against the organisms which produce the ESBL, OXA48, and KPC. Okay, so it does not act against the NDM producing gram negative bacilli. So when you combine with aztreonam, the aztreonam has activity against NDM. So when you combine these two molecules, you can overcome the NDM resistance, which is the commonest cause of carbapenem resistance in India. So this is the reason we choose. So now why not choose, let's say, sulfaperazone sulbactam? It also has a beta-lactaminase inhibitor like sulbactam, which is in the combination like Zavicefta or ceftazidime avibactam. It's avibactam. So avibactam is a newer generation it has this additional activity against the OXA48 and KPC. The sulbactam or the tazobactam were the previous generation beta-lactam inhibitors, which have activity again only against the ESBL producing. So that is the reason we cannot use it with other bacteria. Same thing, if you use meropenem with Astronam, you will not find any synergy. So the reason why this was chosen is to know, because we know the background, how these antibiotics work, what is the likely synergism that is going to help. Putting two combinations of drugs which has a different mechanism of action, and that is to test that we do this test. So if you use, let's say, why not meropenem with Astronam, it won't work because there is nothing that will neutralize the carbapenemase production which that given bacteria may have.
And basically, this piece of information a microbiologist possesses, and that is how he or she is able to choose this. This is not done as per a physician request, is what I'm trying to understand.
See, this is only done in cases where you see a carbapenem resistance. This is
I
not done
see.
in all the bacteria, all the organisms. Only when you
But
see a carbapenem resistance, then only we do it.
But let's say, sir, if I'm dealing with a multi-resistant bacteria in the hospital, can I call up a microbiologist and say, hey, can you run some random combination of two antibiotics and see if there is any synergism? Is that a fair question to ask?
I won't say so, because unless you have a, see, again, these are all standard procedures which has been described or recommended by the standard organizations like CLSI or UCAST. So it is not wise for them to do it just because clinician is requesting, because it does not have any medical support, or you cannot say you can say evidence or even medical logic how a random combination should work.
Right. Sir, one question is there in chat box is about fungal cultures, where it usually report takes a month or so, and then God knows what the sensitivity comes. Can you very quickly mention about fungal cultures a little bit?
Okay. So now fungal cultures, I mean, fungus is usually a very broad spectrum or non-specific term. Let's say there are two types of fungal infections. There are mold-related fungal infections and there are yeast Candida infections. And when I say mold, like Aspergillus and Mucor. Okay. So when we are talking about Candida, which is a commoner infection, you don't need any separate media or anything for Candida infections. Conventional cultures, what we routinely use for the bacteria, they itself grow the Candida. So normal urine culture, whatever we do, or the sputum culture, or blood culture, liquid media, every media can identify and isolate or grow Candida. So when you are suspecting Candida as your primary fungal infection, no need to order separate fungal culture. Okay, so the traditional culture methods are adequate to identify Candida. Now, when you talk about molds, that's in molds, there are broadly Aspergillus-like fungal infections and Mucor-like fungal infections, let's say. So in these, you can order these fungal cultures, which basically they do what they do is they have to digest this fungal tissue. They have to digest the human cells and tissues, and then that will facilitate the growth of fungal filaments. And again, there is a separate agar that's we call SDA, that is Sabarot dextrose agar, which facilitates the growth of fungal infection, the fungal organisms that is used. And again, they have to incubate. There is an incubator for that also, and they have to incubate. And it does not really need weeks. The Aspergillus and even Mucor can grow in few days, less than a week. So no, there is no need to wait for few weeks. Just talk to the microbiologist, tell them that this is what you are suspecting, and usually it grows in few days. And the fungal growth is so much that they are called, some of these fungal infections are called lid lifters. Basically, there is so much filaments that they grow that the agar plate lid is lifted up because of the fungal growth. So yeah, they grow very nicely.
Thank you so much, sir. It is 9 p.m. I will open the floor if there is any questions or comments that anybody has. I will ask Somaraju sir for his comments about the discussion today.
Anoop, and everybody, it's a very important area we are discussing, and so many uncertainties. What looks like when infectious disease specialists speak, everything looks straightforward and simple. It's not that way in a real world of practice of medicine, use of antibiotics. And I would have preferred the participation of a microbiologist in the meeting, and that's extremely important. And it's not enough to just an infectious disease specialist or cardiologist participating. I would have enjoyed it more if a microbiologist participated. Thank you.
Thank you so much, sir. We actually wanted to do that, and we on purpose held back because we thought this topic is going to take a long time. So I wanted to get started first and then do one more session where I can have a more multidisciplinary participation, where we would have already taken care of the basics like what we have done here. So I could be more wiser to ask questions to other stakeholders like microbiologists and whatnot.
Anoop, I just have to also tell you this issue of, say, the choice of antibiotics, the use of antibiotics is almost a social issue. It is not just a microbiology or infectious disease specialist issue. It's a social issue now, and more people have to be involved. Thank you.
Thank you so much, sir. We certainly are going to talk more about antibiotics and microbiology, because that is one aspect which certainly is less explored amongst physicians. And I'm going to conduct these in small batches where I will try to get perspective from various other stakeholders. And that way, probably we will have a meaningful conversation within the given time. As you had seen, just talking basics pretty much took about 45 minutes in today's discussion. Definitely getting more specialists within this stipulated time as a first session would have made us hurry a little bit. But point taken, sir, and this is part of the plan. And I'm hoping I could organize at least 2 or 3 more microbiology session like this.
Sorry, Dr. Anoop, just one moment. Sorry.
Yeah.
I actually spoke to our microbiologist. If they are free today evening at 8 to 9 p.m., if they want to join the discussion, if in case they want to pitch in some time. But I think they both were held up, so that's why they couldn't join.
No, we actually thought about it, sir. We ourselves did not reach out because we thought, let us just do one discussion first to get our basics straight, and then we can have more people, because there are a lot more people involved, not just microbiologists and the physicians. So we definitely want to delve a little bit more into the detail of how the cultures are collected, what are the best practices behind it, what happens behind the scene, what are the insights of microbiologists, and so on and so forth. So a lot of these things, they do need to be discussed. And I don't think a 45, 50-minute will do a justice. But a few sessions on this topic definitely is worth. One question that came on the chat box is, can you please give some examples where you have used breakpoints in deciding the antibiotics so that this becomes easy for you to employ hereafter? Noor, I think that Pratik sir has already answered this question. If I'm reading your question correct, I think you are asking about how we can use breakpoints in deciding antibiotics. So if you could see in the culture report that we shared earlier, that there were,
Sorry, Dr. Anoop, I'll just take a moment. See, like I'll tell you, last week there was one case. Basically, there was an Acinetobacter baumannii in the blood, and the patient was on tigecycline and polymyxin for that. Initially, empirically, we suspected that, and we've started it empirically. And when the final culture report came, now just for the information, the MIC breakpoint for the tigecycline is 2, and sorry, the for the minocycline is 2, and the breakpoint for the tigecycline is 1. So anything less than 2 is sensitive for the minocycline, and anything less than 1 is sensitive for tigecycline. And the observed MIC for both of them was 0.5. So in this case, the minocycline, the efficacy ratio for minocycline was 4 and tigecycline was 2. And again, this was a blood sample. So in the blood, the minocycline levels are much more better. The tissue protein binding for minocycline is not as much as tigecycline. So the blood levels are much better. Tissue, because of the high protein binding, tigecycline has a good tissue penetration and tissue concentration, but it does not have a good levels in the blood. So for this reason, I had chosen empirically as a tigecycline, but subsequently when I saw this report, I had changed the tigecycline to minocycline.
Perfect. Thank you, sir. And that example definitely gives us this insight that the choice of antibiotic is not particularly just based upon the sensitivity report, but also the interaction of antibiotics with which part of the body we are trying to address, to be it blood, be it urine or brain or whatnot. Thank you so much, sir. As I said, we will continue this in the future also. It is 9:06. Unless anybody has got any specific question, we can close the session. Praneeth, your comments, quick comments about today's discussion, and then we'll close.
I'm glad that we brought up this discussion, Anoop, and thank you, Dr. Pratik, for your exhaustive discussion on this thing and trying to break down the complexities into easily understandable and equally practically what happens. And I think I'm glad that we brought up this discussion. And I believe all these non-clinical things which are being said to be outcasts, which but do play an important role or a major role in our day-to-day practice, I think these topics should be discussed. And it's a start, and I think many more sessions will follow, and by which we'll improve our understanding and do better job to the patients. Thank you, Anoop.
Thank you, Praneeth, and thank you all of you for attending today's session. We will be live next Wednesday with another topic. And our series for this microbiologist, we will try to address it probably once every month. So thank you, Pratik, sir. Thank you all of you. Good night. We'll see you next Wednesday. Take care, guys.
Welcome. Thank you all. Bye. Good night.